Hi, this is Brian Wormers talking about respiratory dysfunction in children. I'm going to break this topic down into 3 different slides. The first one will be slides 1 through 4, the next one will be 5 through 11, and then finally we'll kind of cover 12 through 15. As a whole, we're going to discuss oxygen and inhalation therapy. We're going to talk about some of the factors leading into respiratory tract infections within infants and children. We're going to talk about the effects of those respiratory infections. We're going to talk about foreign body aspiration in children. We'll talk about asthma. We'll talk about cystic fibrosis. We'll talk about respiratory distress. And then finally, we're going to talk about respiratory failure. So leading into page 2. So oxygen saturation probes are used in monitoring of oxygen levels. And you are all aware of this. You've seen it in the adult floors with the clip-on monitors or with the wraparound adhesive ones. In pediatrics, we use those wraparound adhesive ones predominantly because the kids will take off the clip-on ones. These may be placed in a variety of different areas. Fingers are commonly seen in the adult worlds, but in the pediatric world, we're going to use it on fingers, toes, feet, earlobes. I've seen it across the bridge of a nose. And on some very, very sick children, we have even put it on penises to monitor that's oxygenation. In those situations where I've seen that was an extremely sick kid that was having septic shock and was not perfusing his extremities very well. But with this, we really want to see that the oxygen saturations are 92% or above. If the oxygen saturations are low, oxygen will be given via appropriately sized devices. So some of these are going to include nasal cannula, simple mask, non-rebreathers, Venturi mask, CPAP, BiPAP, and even intubation if needed. Rarely oxygen causes complications. Some of this can be related to premature infants, and we can talk about retinopathy related to oxygen dosing. Other ways there can be, in cardiac chapter, you'll learn about ductal dependent lesions. And with these patients, if we give too much oxygen, those ducts will close, and the patient is reliant on those ducts to get oxygen circulated throughout their body. And so when those ducts close, then that is bad for your patient. And then in the adult world, you can see COPD. We do not commonly see COPD in children. One main thing that I do want you to remember is to suck out the nose before increasing O's. If you do not have a patent airway, you can put a lot of oxygen on a patient and they still will not be able to breathe. Along with this, infants are notorious for being obligatory nose breathers, meaning that they only want to breathe through their nose. So if they have lots of secretions and that airway is not patent, they really have a difficulty in breathing. So some considerations in the pediatric population is that when they're very young, they still have some maternal antibodies and their infection rates are really quite low. Between the ages of 3 months to 5 months, those antibodies wane and their infection rate is quite a bit higher. So these kids tend to get sick very frequently and very often. When they get to be age 6 or above, their immunity is better because they've been exposed to these things. But you're going to see that this period when they start going out of the house, when they go to daycare, when they go to kindergarten, when they go to these different environments, they're going to pick up different respiratory infections because they're going to get exposed to these things. Other considerations in the pediatric population is that these kids are dependent on someone else for their cares. So if they have somebody that is ill caring for them, then that puts them at risk, of course, to get sick. And that could be a caregiver or other kids at daycare or anything along those lines. Another consideration is smoking, and not directly, they're not puffing on a cigarette, but when their caregivers are smoking. So if we talk about infants and the caregiver smoking and that smoke gets trapped in their clothes, when we nuzzle with a kid and have them, so with an infant, we have them on our chest. Oftentimes we hold them, and so they're breathing in that smoke smell and getting that secondhand smoke from the clothes. Another consideration in pediatrics is that metabolic rate is higher. If you look at their respiratory rate, if you look at their cardiac rate, it is significantly higher than adults. They burn more calories comparatively for their size. and that gets them into trouble faster than the adult world. Also, the size. They do have smaller airways. We're going to see that in the next slide. But a little bit of swelling can make a big difference in kids. They also have a shorter distance from their nose to their lungs, so they're more commonly prone to having pneumonias and respiratory infections like that. Also, their eustachian tube is relatively short and relatively open, and this leads into otitis media, which we'll talk about later. And then, of course, the immunity, that they just don't have the antibodies yet, as we talked about up here. The last one in the slide, we're going to talk just briefly about Pascual's law. So basically, on an infant, if they've got a very small airway, say 4 millimeters, and they have 1 millimeter of edema, you can see what a difference that this makes. So resistance goes up 16 times, and if you look at the cross-sectional area, it diminishes by 75%. Versus in the adult that has an 8 millimeter airway to begin with, it increases by 1 millimeter. It's 3 times that for your resistance, and cross-sectional area will decrease by 44%, which is still very significant, but not as significant as this. This concludes this presentation. The next slide will be covered under respiratory part 2.